Very good afternoon to everyone. So I will be speaking on cataract and trabeculectomy, when and how do we do it. So cataract and glaucoma are both problems of an aging population, and the primary aim of glaucoma surgery is to lower the IOP to reduce the progression, and that of cataract surgery is visual rehabilitation. The choice of combined surgery depends upon the severity of glaucoma and the vision impairment due to cataract.
Can you speak a bit louder? It's not audible.
Right. Combined cataract and filtration glaucoma surgeries has certain advantages, which is primarily the convenience of the surgery and to avoid a post-op IOP spike after cataract surgery. The primary disadvantage being that it is usually less effective for IOP control than glaucoma surgery alone, and there is also increased inflammation, and there may be challenges in doing the cataract surgery as well due to problems in the cataract, as the cataract may be more difficult surgery. So what is the indication of combined surgery? So you have a patient with a visually significant cataract and adequately controlled IOP but significant AGM side effects, adequate IOP control on 2 to 3 medications but advanced glaucomatous optic atrophy, and borderline IOP control on 3 medications at any stage of glaucoma. When not to do, this is also very important. So very high pressure glaucoma where the IOP control takes priority, a trabeculectomy may be better. And an incipient cataract with mild visual impairment and uncontrolled glaucoma, again a sequential 2-stage approach may be better. You do the trab first, and then go for a cataract surgery 3 to 6 months later. Again, if the IOP is well controlled on 2 medications, the patient has an early glaucoma with visually significant cataract, just a cataract surgery may suffice unless drug compliance is a problem. There may be some difficult situations or difficult decisions. For example, in patients with acute or chronic PACG, you have a very high IOP, unrelenting pupillary block, visually significant cataract, and advanced glaucoma. Again, here one must emphasize the importance of adequate medical management and a combined surgery with a very guarded visual prognosis done by an expert. In lens-induced glaucomas with chronic presentations, so for example, late presenting phacomorphic glaucoma, a combined surgery that is undertaken may be ECC or SICS trab, and in phacolytic glaucoma, again, intense steroids initially for inflammation controlled, and the risk of corneal decompensation should also be mitigated and expected and explained to the patient. And patients with sublux lens with pupillary block, again, lens removal with iris fixing IOL or a scleral fixated IOL with or without a trab, the decision again has to be taken by an expert surgeon. Preoperative evaluation, one has to see the glaucoma medications, the best corrected visual acuity, the intraocular pressure, slit lamp evaluation, and the cornea too. You have the gonioscopy, optic nerve exam, the visual field and optic nerve testing, and after adequate counseling, the decision regarding a single site procedure, a single procedure, cataract or glaucoma surgery alone, or a combined surgery may be done. Special consideration, preoperatively one may stop or switch the PG analog to another drug a week prior, may start low potency steroids for a week, start oral acetazolamide if there are no contraindications 48 hours prior, and pre-op mannitol and glycerol, again with all adequate precautions just prior to the surgery. Again, in these cases, periverbal anesthesia may be preferred as the duration of surgery is longer. Of course, some experts do it very quickly as well. And special considerations in cases where there is poor mydriasis, again high density OVT where there is endothelial problems, and trypan blue or mitomycin C as per requirement. So types of surgery, phaco trab is usually done 2-site, SICS trab is done as a single site procedure, ECC trab is usually a single site procedure. So the advantage of a single site procedure is that it saves time, and the primary disadvantage is that there is excessive conjunctival manipulation that may lead to a trab failure. 2-site surgery technique for cataract surgery, definitely there is improved exposure through a temporal approach. For a trabeculectomy, it enhances bleb survival and there is rapid visual recovery. The primary disadvantage is that it may take longer. IOP control with single site or 2-site, both approaches are effective, but a 2-site may have a better IOP control. So how do you do a 2-site technique? So you may give a subconjunctival injection mitomycin C, which is my preferred choice. You leave a conjunctival flap and then dissect thoroughly posteriorly, irrigate the area well to remove any leaking mitomycin C, dissect the scleral flap well into the limbus, very careful dissection, and then, after this we proceed on, once this is done, we move on to the cataract surgery. We move temporally, shift the microscope, and cataract surgery is routine. You just leave the flap there and then go ahead and do the cataract surgery, implant the lens, and then move back again posteriorly. With the visco in situ, we create the ostium, and the visco inside prevents AC collapse. I also like to do a releasable suture to provide against additional insurance against a bleb failure. Releasable sutures are very convenient here. Yeah. And then once the surgery is complete, we just used buried conjunctival flap knots. Buried knots again prevent irritation to the patient. Yeah. And complete the surgery with intracameral moxifloxacin. Again, avoid subconjunctival gentamicin to prevent bleb failure. Single site phacotrap is, as you can see in this photograph, is done. The phacoemulsification is done through the same site as the trabeculectomy flap. And most surgeons have now shifted from single site to two site because the failure rate with single site tends to be higher, and hence I'm not showing surgical video for that. SICS trap is again usually single site, a superior peritomy with mitomycin C, a little tunnel is done for routine SICS, and entry is usually slightly posterior than usual. The SICS, a routine SICS is done, IOL is implanted, following which you can use a Kelly sponge to just do the sclerectomy, and then the iridectomy, and then the conjunctival closure is done. And then, yes, the flap can be sutured as a single suture. One can use a releasable flap also for this procedure. It is a surgeon's choice. And then you just close the conjunctiva. Yeah. So postoperative management is similar as that of glaucoma surgery, just that the patient has to be seen on the first post-op day and then weekly again. If there is significant inflammation, more visits may be necessary. Post-op, usually you give antibiotic steroid, and steroid tapering is usually slower. Cycloplegics given in PSCG. And complications are similar to that with cataract surgery alone or with TRAV alone, but the risk of persistent hypotony and endophthalmitis is increased with antifibrotic agents. So take-home messages: avoid combined surgery in high IOP situation due to high failure rates. Pre-op steroids may be useful. Two-site surgery with antimetabolites ensure higher success rate. Avoid subconjunctival gentamicin. Prefer intracameral moxi. Avoid aiming for hypotony. Visual rehabilitation is better. Use releasable sutures, which is an insurance against bleb failure, and SICS and TRAB may be taken, or ECC TRAB may be done in difficult situations. Thank you for your patience and time.
Thank you, ma'am. Nice talk. How many releasable sutures you use?
So it again varies. One can use even 3 releasable sutures, or you can just put a tip releasable and 2 side sutures. Depends. If you once you put the releasable, you look at the filtration through your ostium after removing the viscoelastic. And if it is over-filtering, you can go ahead and put 2 more releasable sutures. You remove the viscoelastic.
What is your routine?
My routine is 1 releasable and 2 side sutures. I usually do that. And sometimes I might use 2 releasable sutures.
Will you do combined surgery in a uveitic glaucoma with cataract?
Yes. So I would not prefer to do a combined surgery in a uveitic patient. I would, if the IOP is high, I would go for the TRAB first and then leave the patient alone, because the inflammation risk is too high. So if I have given a posterior subtenon or a Ozurdex and the inflammation is taken care of by my retina colleague, then I might think about doing a combined surgery. But in a uveitis patient, I would distinctly avoid it. I would go for a 2-stage procedure instead of a single surgery.
Combined surgery with nasal trap?
Combined surgery with?
Nasal trap. Nasal in the nasal quadrant.
Yes, because you want to preserve the other quadrants in case you, usually in glaucoma patients, it's a good idea not to use up the entire conjunctiva, because there is a very high chance the patient might require repeat surgeries. So if you put it to the nasal side and then you have more conjunctiva left, if you want to do a repeat trap, and then if you want to do a GDD later on. So it may be a good idea to just do it in a small area. And I do the nasal side, but I do the temporal side also. But I usually leave adequate conjunctiva for any procedures that the patient might require later. So I usually leave as much of conjunctiva untouched as far as possible, sir.
Sorry, failure rate.
Failure rate, again, sir, I don't have the data for it because I have not looked at studies, but generally failure rate of combined surgeries is slightly higher than that of TRAV alone. That is, but this again, as I said, I do not have the data for it. But yes, that is primarily related to the inflammation. But in experienced surgeons, I've seen many experienced surgeons who have a good success rate with combined surgery alone. Now, if again, success can be either a complete success or a qualified success. If you do a TRAV alone, you're most likely to get complete success. If you do a combined surgery, you may have to add on a drug maybe, but so you would end up with a qualified success at least with the patient most of the time. So, yeah. So, in where it is indicated, it may be done. Welcome, sir.
Thank you, ma'am. Dr. Vaibhav Kumar Jain, please. Dr. Amit Porwal. Nobody wants glaucoma. Dr. Devendra Maheshwari. He's coming? Thank you. Dr. Prachi. Welcome, ma'am.
Good afternoon, everyone. Good afternoon, sir. My topic is diverse presentation and eclectic outcomes in lens-induced glaucoma. Basically, lens-induced glaucoma can be classified into two types, as all other glaucomas are classified: open angle and angle closure glaucoma. In open angle glaucoma, there are phacolytic, lens particle, and phacoanaphylactic type of glaucomas. And in angle closure, phacomorphic, phacotopic, and pupillary block glaucoma. The phacolytic glaucoma, the term was coined by Flox, and Epstein was the person who described about the high molecular weight lens proteins which are involved in the pathogenesis of phacolytic glaucoma. Many a times in phacolytic glaucoma, what happens, the diminished vision is for a very long period, maybe it can be of months or years prior to acute onset of pain. And the patient many times comes and says that he developed a sudden pain or a headache or redness in last 1 week in last 3-4 days, but the process might be continued for a longer duration. Pathophysiology, basically there are two theories: macrophage theory and soluble lens protein theory. Macrophages, they get accumulated. Why? Because high molecular weight lens proteins are collected as the age grows. These high molecular weight lens proteins get accumulated into the lens cortex. And because of the accumulation, stretching of the lens capsule occurs, and there occurs micro defects in the lens capsules. Through those micro defects or micro openings in the lens capsule, these proteins leak into the anterior chamber and also into the vitreous cavity. The macrophages now engulf these high molecular weight lens proteins, and they obstruct the trabecular meshwork. Similarly here, high molecular lens proteins per se itself may go and obstruct the trabecular meshwork and ultimately block the aqueous outflow. And both the processes ultimately lead to acute rise of intraocular pressure. I'll present my three of my cases who came to me with the same, with some of the phacolytic glaucoma symptoms. First case is 64 years old male. His left eye was operated 8 years ago with his best corrected visual acuity of 6/9 and IOP was 11. Right eye, he came with acute sudden loss of vision with severe pain, redness, watering since last 4-5 days. It was not associated with any floater or colored halos or trauma or discharge. Findings in the right eye, in which the phacolytic attack was there, glaucomatous attack was there, vision was PL positive, PR was inaccurate in the temporal and superior quadrant, mild circumcorneal congestion, mild corneal edema with generalized haze, anterior chamber was full of white material giving a milky appearance, pupil was not at all visible, anterior chamber depth could not be assessed because of the hazy media, intraocular pressure in the right eye was unrecordably high, and digitally it was stony hard. B scan, we found that it was within normal limits. This was the patient. I did SICS in this case. small incision cataract surgery as phacoemulsification. I couldn't see the capsule. I was not aware of the condition of the lens and zonules. So SICS was done, lens was removed, and simultaneously I did PI also. You can see in the inferior central image of the inferior line, and this was the condition of the eye after the surgery. After 1 week, the cornea was clear, pupil was round, pupil though it was mid-dilated and non-reacting, and after a month, I was perfectly okay. I did yak capsulotomy because there was early posterior capsular opacity, and his BIS corrected visual acuity was 6/12 with pressure 14. Another patient, right eye was perfectly normal, left eye he had pain and redness since last 25 days associated with headache and recurrent vomiting. He was treated for some gastrointestinal diseases. It was misdiagnosed by a GP for last 3 weeks, and so the eye was not found to be the culprit. It was found something else, and his left eye had high intraocular pressure with which was 48 millimeter of mercury, and B scans was normal. Severe cells flare. Pupil was mid-dilated and pupil was faintly visible in this case with deep AC. This was the condition preoperatively. After I did phacoemulsification, this was the last photograph of giving subconjunctival injection after completing the phacoemulsification. I didn't either do the PI in this case. First post-op day, the condition was this. Cornea was hazy with some microcystic bully and mild reaction was there. After 1 week, we can see that multiple bullies were there. Vision was 5/60 and intraocular pressure was still 20 millimeters of mercury. CD ratio could be seen, that was 0.4, and NRR was healthy. Third case was a female. She came with this condition, having some KPs and in her left eye. In this, minimal circumcorneal congestion was there, but she had the complaint for last 1 year and she ignored her complaint, and flare, thin reactionary membrane, mid-dilated non-reacting pupil was there, pressure was 52, and B scan showed some hint of optic atrophy. I did temporal SICS in this case. Pupil was round, regular, but not fully constricting, but pressure was 18, and after seeing, the CD ratio was 0.99. She couldn't gain vision. Another problem was there was a scleral necrosis in this case because I did temporal SICS. On day 15th, I saw a scleral gutter and necrotic area there, and by the 30th day, it started resolving, and after 2 months, it was completely recovered without giving any scleral patch graft or any surgical intervention. It was automatically covered by lubricants and antibiotic drops. Steroids were stopped in this case. But she didn't gain good vision, as PR was inaccurate in this case and CD ratio was 0.9. So the outcome of my 3 cases were, in first case, there was good visual recovery because corneal health and retinal nerve fibers were preserved, as the surgery was done within 4 to 5 days. Second case, partial recovery of vision was there. Endothelium was compromised, but retinal nerve fibers were preserved, as the surgery was delayed for more than 3 weeks in this case. And in the third case, nil visual recovery was there. Cornea was normal, but retinal nerve fibers were lost, as raised IOP was almost for an year, as the patient ignored her symptoms. Take-home messages: patient can be confused for gastrointestinal or any other systemic diseases. Mostly patients one eye is having operated for long and they were satisfied with the one eye vision, so they ignored their other eye. Ultrasound is must to rule out any posterior segment growth like masquerade syndrome or retinal status, RD and all, and also to prognosticate the cases. Earlier the surgery performed, better is the result. IOP reduction followed by closed chamber surgery should be performed. IOP should be reduced after mannitol or anti-glaucoma medications. Inaccurate PR is not a contraindication for cataract surgery in phacolytic glaucomas, and trabeculectomy is not required in these cases. I did temporal SICS. Why? Because I wanted to preserve the superior part of the conjunctiva in case future trabeculectomy was required. And that is all. I'll rest my talk. Thank you so much.
Nice presentation. Any questions? Can I make a comment?
Pardon, sir?
I wish to make a comment.
Sure, sir.
This is my thinking, and in facultative glaucomas, we have to separate doing the CCC and decreasing the intralenticular pressure. The surgeon is sometimes under pressure to do the phaco. There are so many techniques described. We can do a YAG laser puncture,
Puncture.
and
Okay, sir.
puncture with a phaco needle, or a micro CCC, decrease the interlenticular pressure.
And then,
There was no need of doing temporal CCC.
sir, I couldn't see anything, but actually, one of my case, I do not have my pictures of that case. What happened? I took the case, as I decompressed the anterior chamber, when all the secretions or all the collections were cleared off, the zonules were so lax that the whole of the lens came out through the dilated pupil. The lens was above the iris with lax zonule. So in that case, anyhow I managed to do the capsulotomy, can opener and envelope technique, put the lens. Next day patient was okay, slightly subluxation was there, but ultimately that lens dropped into the posterior segment. So I thought, if in case I do phaco without and pressure is generated during phaco, it may lax tissue it may go behind. That was the reason of doing temporal SICs in this case.
Very nice, ma'am. Another idea is one should always practice for the rainy day. For the rainy day means the facultative glaucoma. Like even in a normal cataract, one can just, if you have the time, just try doing a double CCC, 2 CCC. I have on record doing 5 CCCs in a single eye. So I was in the mood, I did it. I'm not praising myself. Just I'm suggesting, so that once you get such type of cataract, you know what is to be done, what suits you. Then you should know whether you want to do a CCC clockwise, you want to do anti-clockwise, you want to do with a needle, you want to do needle clockwise, you want to do needle anti-clockwise. Then you have your preferred pattern. You do it all the ways. Needle clockwise, anti-clockwise, CCC clockwise, anti-clockwise with rhexis, forceps. Then you find a way, then you do in normal eyes. Eventually one day you will find a difficult case and you will do easily. I do a small CCC, micro, then cut it and do with sodium hyaluronate. But it is a very good presentation.
Thank you. Thank
Nice presentation, ma'am. I would take this opportunity to ask the House on the relevance of PI in all these cases.
That was slip
iridectomy.
of tongue, the YAG puncture of the lens capsule.
No, sir. Like peripheral iridectomy, surgical peripheral iridectomy in such cases.
In first case, I did surgical PI, but in other cases, I usually do not do that. Why? I just wanted to do a study also, doing surgical PI in facultative, in long-standing, in early cases, but the study is still going on. It is not yet completed, so I cannot comment that. I just wanted to see the lowering of IOP after doing PI and without PI. This I wanted to do a study. That was the reason. Thank you.
Dr. Amit, please, he is a very distinguished surgeon.
So, good afternoon everybody. Welcome to this glaucoma session of Glaucoma Potpourri. So, I am going to talk about mix, the incisional goniotomy, plus bang or KDB. But no financial disclosures. The phrase mix was coined by Dr. AIOCMT3. He has revolutionized the glaucoma management with minimal tissue trauma, good post-operative recovery and improved patient satisfaction. So, what is the definition of mix? Basically, mix constitutes a group of surgical interventions which share 5 common characteristics. They should have high safety profile, they should be minimal disruption of the normal anatomy, we should have an ab interno approach, and the efficacy of mix should offer meaningful lowering of IOP, and they should be easy for both the patient as well as the surgeon. So there are various approaches for mixed procedure, but I am going to talk about the trabecular meshwork approach, which is the incisional goniotomy, that is by increasing the aqueous outflow from the trabecular meshwork and Schlemm's canal by tissue removal, either by bang or KDB. So what is this bang or KDB goniotomy? Basically, you excise the trabecular meshwork tissue. This bypasses the trabecular meshwork and forms a direct pathway to the Schlemm's canal for 4 to 5 clock hours. It can be performed combined with cataract surgery or as a standalone procedure in a phakic or a pseudophakic patients. So we all know what are the indications for this incisional goniotomy, especially the most popularized. These are the 2 most popularized mixed surgery in our country, And any form of glaucoma, I would say we can try this procedure. Only thing is we should avoid neovascular glaucomas, and plus in new angle closure glaucoma, this has to be combined with the GSL, that is the goniosynovitis. So even in failed TRAPS, mild glaucoma, moderate glaucoma, even advanced glaucoma, if the patient wants to reduce the number of medications, you can try this. It can be an indication. So contraindication, I told you, basically active NVG, corneal opacity, ankle dysgenesis, or elevated epithelial pressure, venous pressure is there in some conditions, then you should avoid it. So what is the ideal candidate? Basically the patient should have cataract. Initially when you're going to start with mixed procedure, this is the ideal candidate. Cataract plus mild to moderate open angle glaucoma. Goal should be to reduce the IOP by 20 to 30% or in mid-teens, and to reduce the number of glaucoma medications. So what are the equipments needed? Basically a surgical gonioscope, cohesive viscoelastic, Kahook dual blade for the KDB, or a 25-inch hypodermic needle. So after phaco and IOL implantation is done, you have to fill the AC adequately with the cohesive visco. To get an end-face view of the nasal angle, you tilt the patient's head away from you by 35 to 40 degree, and tilt the optic of the microscope, the eyepiece of the microscope, towards you by 35 to 40 degree. Apply viscoelastic, the cohesive viscoelastic, over the cornea, and place the surgical gonio lens over the cornea, and try to visualize the angle. So this way you get an end-face view. So then the central point of the nasal angle is penetrated with the tip of the bang needle or the KDB device. Thereafter it is advanced 60 degree inferiorly and superiorly, so as to have 100 to 120 degrees goniotomy. So goal is to excise the pigmented part of the trabecular meshwork and expose the Schleier's canal into the anterior chamber. A reflex of blood after the ablation indicates that's a good sign. That means you have reached the appropriate depth. Bang is the only low cost mixed procedure. All you need is a 25 gauge hypodermic needle and needle holder to bend the tip. A goniotomy is fashioned by bending the distal 1 millimeter of the needle towards the bevel at about 75 to 80 degree, and this can be used to perform the goniotomy for 120 degree. So you can see in this case I have implanted the IOL. Now I am showing how to prepare the needle. So just the anterior 0.5 to 1 millimeter is bent about 75 to 80 degree, and this gives an adequate support. And this is the way you are going to prepare the basically the needle. And now once you have prepared the needle, you have positioned the patient and the microscope, apply cohesive viscoelastic, place the Schwann-Jakob lens, and try to first identify the angle structures in low magnification. Once you identified in low magnification, you can increase the magnification and try to strip the trabecular meshwork with this bang needle. You can see as you are stripping the trabecular meshwork, you will see there is a oozing of blood. That means it's a good sign you are cutting the trabecular meshwork and you are in the right plane. So you can start this from the center point, go inferiorly, and then you can go opposite side, or you can go superiorly and again join the initial part where you are cut. So this is the way the bang procedure is done. Sometimes what happens is after this procedure there might be a good amount of oozing of the blood, so nothing to worry, you can just do hydrotamponade, and in this patient you can see that the TM strip was floating around. So with the help of a microrexis forceps or any micro instrument, you can just peel off the trabecular meshwork strip which is there. You saw in this procedure how it was done. So this is another case basically. Again after positioning and putting the cohesive viscoelastic, place the Schwann-Jakob in low magnification, identify the structures. So you can see I have penetrated the trabecular meshwork and just stripping it off. You are not supposed to be too deep, and you can see in one go how nicely the whole trabecular meshwork is stripped off. It is very easy and can be performed if you know the angle structures. Visualization of the angle structure is the key for the success of this surgery. So you should be able to visualize the angle structure adequately. So what is the advantage with this bang procedure? Because of the one is the economy, and the bevel and the lumen of this hypodermic needle, they combine to form two cutting edges, and this basically forms like a double blade goniotome which is capable of excising the tissue and block. And the dorsal portion of the bent needle acts like a guard, which is the smooth portion, and it prevents incision of the posterior wall of the Schleier's canal and helps maintain the plane of excision. Coming to the KDB goniotomy, it's a single-use disposable blade, and it has a sharp tip to pierce the trabecular meshwork. It has a ramp which stretches the trabecular meshwork, and these dual parallel blades which create a parallel incision in the trabecular meshwork. There is a rounded heel and the tapered sides, and this is a smooth foot plate also. So this gives the ease and protection to the Schleier's canal. This is the way the instrument looks, but it comes with a cost. It costs about 30,000 rupees for this instrument. So this is just a wet lab demo of how you do a KDB. This is the demo eye. You enter the anterior chamber, fill it with cohesive viscoelastic, place the cohesive viscoelastic even over the cornea, and you can place the surgical lens. This brown part is the trabecular meshwork. Now there are different techniques when you are doing the KDB. Use the KDB, you have mark and meet, you can excise on either direction. So whichever way you are comfortable with, you can practice it in the demo eye first. You see I have marked the incision for trabecular meshwork first, then I have gone behind superiorly, and then I am just extending the incision, cutting the trabecular meshwork and meeting the initial point which I marked. So this is way you can just practice your KDB goniotomy in the wet lab, and this is a live case. Again, positioning is very, very important, and the role of cohesive viscoelastic has to be emphasized. This is a contactless bench surgical gonioscope. It's a hands-free gonioscope. You just have to touch your finger. I have marked my trabecular meshwork. I just incised it, and now I'm going superiorly and cutting the trabecular meshwork and joining the initial mark. So this is very, very easy, but the only problem is it comes with a cost, and there can be some complications in these procedures. Hyphema is the most common complication. There can be peripheral anterior synechiae, transient IOP elevation, and post-operative inflammation, but they are not much. So to conclude, both BANG and KDB provide safe new options for IOP reduction and reducing the number of anti-glaucoma medication. It has low risk, low cost, and it also preserves the tissue for further any glaucoma management. Thank you.
Very good. BANG versus KDB, which is more effective?
So I've done a study comparing BANG and KDB both. So at 4 weeks, KDB gives better IOP lowering, but when we compare statistically, it is not significant. And at the end of 12 weeks, both BANG and KDB has equal IOP reduction. So we won't say one is superior over the another, but when we look at the cleft, the KDB cleft is more prominent, whereas the BANG cleft is not so prominent. But I believe that once we have cut the trabecular meshwork, the collaterals open up, and that's how the IOP reduction is there both with KDB and BANG, which is not statistically significant at the end of 3 months.
Do you do post-op 2 months checkup or 1 month checkup?
So my study,
BANG?
I presented this in one of the conferences, and I got an award for this. I check all my patients week 1, week 4, week 12. So this is the standard protocol. If in case any event occurs, then I call them for follow-up earlier also. But my follow-up is there from last 6 months now.
Incidence of anterior synechiae and BANG?
So to prevent peripheral anterior synechiae, basically what I do is I give pilocarpine once in the night for at least 3 to 4 weeks after the surgery. So this keeps the iris away from the incised part, and the occurrence of PAS is reduced.
If there is a gross hyphema, will I give atropine or will I give pilocarpine?
No, if there is a gross hyphema, I would mind giving an atropine, homide basically, because atropine will cause more dilatation, homide will be sufficient. But there is no formation of pus even with this homide or atropine, because you are going to give it only for 3 to 4 days, and then you are going to stop it and again start with pilocarpine.
Long term, did you have any complication when hyphema is not resolved in 10 days?
Never had an issue with non-resolving hyphema. Only one patient had an hyphema which was there for at least 5 days, but at the end of 5 days, the whole hyphema cleared off. This blood had oozed from the bag behind the optic also, but after 5 days, the whole thing cleared off. So hyphema should not be an issue. Hyphema is more an issue with the GAT procedure, but not with these two surgeries.
Small query, any incidence of DM detachment?
Yeah, I had, so this DM detachment, my friend Dr. Devendra is there. I had shared him the picture. So during my learning curve, so I did the procedure, everything very nicely, but and I got a habit of injecting air before I close the wound. So when I injected, I realized a nice donut shaped DM was detached towards the area where I had incised. But it doesn't make a difference. You inject air, just tap the cornea and the DM gets attached, and you don't have any problem. So DM detachment, ciliary body damage can be there if your visualization is not correct. So that's why I always advocate that at least practice first gonioscopy in all your patients, cataract patients routinely. Just practice your gonioscopy and then go to intervene. Don't do the procedure without practicing gonioscopy.
How many doctors who are not doing it? Any practical tips you want to give them while doing BANG?
So that's what, first get the lens. For every Indian, cost is a factor, because if you go for the Schwein-Jakob, which will cost you 48 to 50,000, so buy the disposable gonio lens, which is available for 4 to 5,000 rupees. You can ETO it. Start practicing gonioscopy after every phaco. What you do, not only phaco, even if you are doing SICS, start practicing the gonioscopy. After you put the IOL, visco is there. Position the patient as I mentioned, and start practicing visualizing the structures. Once you have started visualizing the structures and you are confident, then prepare the BANG needle, introduce into the anterior chamber, go towards the trabecular meshwork, and just rotate. Don't cut. Your wrist has to be free. So start practicing steps first approach. So once you know that your hand is moving freely now, then you can start the procedure. But before that, start practicing without damaging the tissue.
I will just add, table has to be up, the surgeon's stool has to be very down, patient tilted out. Even in my case, we choose the location also. Like if it is a right eye, like around 4 feet for the surgeon's stool should be available.
Yeah, so what happens is once you tilt the head and the microscope, of course, the position in which you have done your cataract surgery changes because the focal length changes. So you have to reduce your stool and then visualize the structure.
What I'm saying is, if the two surgery tables are lying together, then it is better to do left eye on one side.
The positioning of that is like temporal exercises, two tables, how you do. So your positioning of the patient has to be there properly, right eye, left eye, where you are going to position.
Any questions for Dr. Amit? Are you doing eye stent?
Pardon?
Are you doing eye stent?
I've not implanted an eye stent yet because cost is an issue at our place.
One is like anybody who's doing eye stent, you can get the eye prism from them. It is, you can ETO. Anybody can ETO. It is quite cheap.
Yeah, any disposable gonio lens which are available for 3,500 to 4,500 rupees. So there are a lot of surgical gonio lens available in the market. Ocular, Catina, you can buy anyone. National, I think North India National is the distributor for them.
The cost is not the issue. My
cost is
message
not
is
the
this.
issue. Yeah. Thank you.
Now we have very renowned doctor, Dr. Parul, please. We have a very renowned surgeon from North India, Dr. Parul, please.
It's okay, the picture is popped up on its own. But what I wanted to show was if you have an elderly gentleman without glaucoma also, and if they're putting milk in a white mug, it is really difficult for them even to appreciate contrast. And if we talk about a glaucoma patient where contrast is already compromised, the job is even more difficult. So just by changing the color of the mug, you can make the life of these people easy. So that's how much relevance contrast carries in your day-to-day life. So what I really want to do in the next coming few minutes is to sensitize you about the relevance of this often ignored test, which is a relevant part of the visual function. Slides aren't moving. So yeah, so this study asked about 100 plus glaucoma patients what they actually saw. So typically we have been shown that there is a tunnel vision for glaucoma patient, and we have that picture in our books. But when the patients were asked about what they really face, they said that what they really needed was more light, and especially when they were moving either coming in from a dark room to bright light and vice versa. Real life is not as easy as viewing alphabets on a Slethen's chart where the contrast is really very pronounced. Especially at dawn and dusk, it is very difficult for patients and elderly individuals to differentiate between the curb and to look at the road ahead. So it's very important that we focus on this contrast sensitivity, especially for glaucoma patients where the disease itself is adding on to a compromised contrast in addition to the age. Several studies have already established the importance of contrast sensitivity and its decline in not only established cases of glaucoma, but also in ocular hypertension and pre-perimetric glaucoma. There are now studies coming up which are actually telling that how much dropout in the retinal nerve fiber layer thickness reduces the contrast sensitivity by a certain number of log hours. Now this may vary for patients with early, moderate or severe glaucoma, but it just makes sense to ascertain contrast sensitivity as a test and correlate it with the OCT RNFL that we are doing. Now I'll show you why this carries more relevance in severe cases. Now having established that this is something that is getting affected in glaucoma, let's have a look at the tools for contrast sensitivity assessment. Since time immemorial, we've been talking about contrast based, the chart based test, especially the Pelly-Robson chart, which actually suffers from fading over a period of time, and since there are optotypes on the chart, you need a literate patient to do that test. Now tests are coming up either on mobile based systems or computer based tests, which can actually give gratings which are not dependent upon either the literacy or fading effect. So the test that I would be talking about is the Spaeth-Richmond contrast sensitivity test. At this point of time, it is a free test based online. You just have to create your account and your patient's data is stored in the cloud. And I've been using this test now for over 5 years, and my patient's data, even the follow-up data, is saved in the cloud, and I can see how somebody has deteriorated or status quo. So basically what this test is doing is it is providing you information not just for the central quadrant, also for 4 peripheral quadrants, which no other contrast sensitivity assessment tool is providing you the information. So each quadrant carries a value of 20. Since there are 5 quadrants now, the total value is 100. So what value of sparks is suggestive of glaucoma? So the tests that have been done in the studies that have been carried out in Caucasian population have shown that any value of the total spark score less than 70 has shown to be 80% sensitive and 93% specific for glaucoma, and even glaucoma suspects have the dropped value of spark score. So that's something to really look at. In addition to doing an RNFL, we can do a contrast sensitivity testing even for our glaucoma suspects. So we did our own study to see is sparks good enough for detecting glaucoma, and we found out that it was robust and better than Pelly-Robson, both in sensitivity and specificity for detecting glaucoma in various severity stages. Now when it comes to progression, we know that especially in patients with moderate and advanced glaucoma, outer field may already be depressed and the reliability will reduce over a period of time. And with OCT, we know that there are chances of floor effect happening as the disease progresses. So in these cases, how do you ascertain that your patient is deteriorating further? Their studies have shown that contrast sensitivity can help you pick up subtle changes. Although there are no concrete values in literature at this time point to show that 10 units change in the contrast sensitivity means that there is a progression, but still there are relevant studies which have shown and which have picked up that rapid visual field progression, these patients have a significant decrease in the contrast sensitivity. So if you have a patient and you are doing the visual fields and you see that there is a progressive decline in them, you can corroborate your findings of the visual field with the contrast sensitivity test, and you would find out that you are able to detect progression at a much earlier level. Again, we in our own subset of advanced glaucoma patients, we had severe POAG patients in which we compared sparks with Humphrey visual fields at baseline 1 year and 2 years, and we found that sparks was able to detect contrast sensitivity earlier than the visual fields. So this is one of the representative cases, and this is how the outcomes look like. This is the baseline of a patient with advanced glaucoma, and you see that 2 years later there is a drop in values in almost all the 4 quadrants of this patient. Does intervention improve contrast sensitivity? Yes. So this study we gave travoprost to patients, and we saw that the contrast sensitivity parameters, both peripheral and central, improved after 3 months of giving prostaglandin treatment once the intraocular pressures were controlled. So what is the practical application of talking about an additional test which we are doing? We need to focus at visual rehabilitation of our patients also, not just giving them treatment or doing surgery, because their day-to-day vision related quality of life is very important. Highlight the better lighting to create a better contrast. If somebody is getting down the stairs, the margins of the stairs can become very difficult to appreciate, so yellow taping or red taping can be done at the margin of the stairs. You can just increase contrast. So even if somebody is wearing a watch, a white dial with black straps and black arms, and similarly for other day-to-day activities, options with specific apps on smartphones, tablets and e-readers can be done. We need to understand that visual acuity is just one element of visual function. Contrast sensitivity carries a lot of relevance, especially once the age is increasing and you have additional diseases like diabetes and glaucoma in patients with increasing age. So different contrast sensitivity tests exist. You can pick up any of your own choice, although at this point there is no clear consensus on which method is optimal, but you have now seen that even in ocular hypertensives and pre-merimetrics, there is a decline in contrast, and you can detect disease progression even in these patients before they actually develop an established form of glaucoma. So at least start checking contrast sensitivity, and if possible you can use sparks as a tool because it gives you additional information about the peripheral contrast sensitivity as well. Thank you so much.
Madam, apart from Spaith, which other app you're using? Actually, I have never used, very frankly. We never thought about it. Congratulations to you.
I now use Sparks along with pelirobsin because in order to show to the world that this really works, I've been doing it in a lot of other studies. I'm using this for IIH patients also to see whether there is a decline in contrast with decreasing edema. In patients who are taking hydroxychloroquines, in patients who are on isotretinoin and even on ATT. So checking contrast with all these disorders where, basically any place where optic nerve function is getting compromised. So this really helps to pick up certain cases in time.
Any app on the Play Store available? Nothing.
This is an internet-based test on it, which you can do on a desktop. So if you use a tablet, the sizes of the tablet would vary, and on a phone, the contrast itself is so variable with each device that you won't be able to get, certain standardized subset of data. So it is always better to use the same computer that you're using. So any laptop or a desktop is good enough. And at this time, at this time point, this is a free test. So, and your data is safe in the cloud.
Any practical guidelines, practical tips, like room lighting, distance?
Yes, so to be sitting away from a window, the tube light should be behind the screen. It should not be a totally dark room, a dim lit room with that standard parameter on every visual field testing. The patient just has to see the gratings that appear. They appear randomly either in the center or the peripheral 4 quadrants, and they just have to press the space bar the moment they see the screen. So that's just about it. There's nothing, even illiterate patients, even elderly patients of 80 years of age are able to do it. The gratings are prominent enough for them to be picked up. So that is one additional advantage. And this test is not prone to any fading or any other literacy related issues.
There are a lot of companies which give digital charts which have contrast testing. Do you recommend it?
Yes, no, I don't. I've tried several. Even with this, in the same day also, I've done some of the tests on my own subset of patients. There are variable responses. So even when the battery of your tablet or your laptop or your phone, it's starting to decline, the illumination of the screen changes and the outcome changes. So it has to be a fully charged system, and preferably not a phone or a small tablet. Desktops, especially for contrast sensitivity, provide robust results.
Cataract interferes?
Yes, cataract interferes.
Ma'am, what are your views on yellow IOLs in respect to contrast?
I'm yet to see any change because a few of our patients who are on follow-up have received yellow IOLs, but there is no influence of, if you compare with the patient with a similar degree of disease, there is no influence of a yellow IOL or a clear IOL. But having said that, multifocals influence the contrast sensitivity. So I've not tried doing the test on patients who have had a multifocal IOL.
Ma'am, will you recommend, carry forward, advanced glaucoma, will you recommend a multifocal if a patient is insisting on a multifocal?
No.
Lifestyle?
I don't. I've seen unhappy patients. I don't. EDOF, yes, but not a multifocal.
Thank
At
you.
least for me. Yeah.
Thank you.
Thank you.
Do we have Dr. Guhar Ahmed? Sir, welcome, sir.
Good afternoon, everybody. Where does this go? Well, though I'm a last speaker, what I'm going to speak is one of the very rare entity, rare and interesting case of a choroidal melanoma which presents as acute congestive glaucoma, left eye in a 55 years. In my experience of about 50 years experience, I have come across one case. And my dad was a legend in the field of ophthalmology and ENT, J&K. Early 70s, he saw a case when he had only direct ophthalmoscope. Today we have got a lot of modalities. We have direct, indirect, A scan, B scan, MRI, CT, fundus fluorescence sonography, OCT, angiosity, and yet it's unfortunate that either due to bad luck of a patient or a ophthalmologist, the patient. So I'm just giving a narration about choroidal melanoma. This is a Dal Lake, and we have got this houseboat. Choroidal melanomas are one of the commonest. I have presented this paper in Massachusetts for about 25 minutes as a keynote speaker, but here in 6 minutes I will just rush. Maybe I will not go the picture. Choroidal melanomas are one of the commonest intraocular tumors, which are benign, malignant, pigmented, non-malignant, more in whites than in blacks. They are 80% choroidal, 12 and 8% involved in the body and iris respectively. They are about 6.5 per million in USA and 7 per million in Denmark and Scandinavian countries. Very difficult to diagnose because of atypical manifestations. However, by A scan and B scan ultrasound and direct, we just pick up a solid or exudational detachment. Diagnostic modalities are direct, indirect. I have already told you about that. So, what is the presentation? If the tumor is anterior to the lens, patient may come across with a blurred vision, parasitic scotoma, and painless visual loss. If the tumor hits the angle of filtration, patient may come as acute congestive glaucoma, creeping glaucoma, secondary glaucoma, ocular hypertension. If the tumor hits the vitreous, patient may come across the vitreous floaters. Sometimes ocular pain may be only presenting feature. In very rare cases, you may get loss of appetite, blood control. So in 2011, a 55-year-old patient came across with the presentation of acute congestive glaucoma, was put on a full battery of acute treatment. Even all the battery, I mean, this osmotic diuretics, 500 cc of intravenous mannitol, he didn't respond to the treatment in 8 hours. So at that time, no B scan, ultrasound was done. He left, he was advised admission, he went Lama, he was sought a second opinion. This time the ophthalmologist of B scan picked a solid detachment. Unfortunately, he was referred for MRI. There was a problem of a radiologist renowned. So he just did not radiologically confirm the melanoma. So there was a mistrust between the ophthalmologist and the patient. He left Lama for 2 years. And in 2 years' time, it was 11 to 13, he was left with a painful blind eye. I saw the patient in 2013, and I was lucky to have the reading of my dad. So I did this MRI, sent him to a very young, who confirmed the radiological confirmation of the melanoma, and his findings were optic neurochiasma radiation and the tract normal, pituitary fossa, basal ganglia normal, midbrain thalamide. So the modalities of the treatment of the melanoma are, if it is less than 22 millimeter observation, more than 22 ejaculation, plaque therapy, block resection, varus vitrectomy, binodal vitreation. So what I did is I did I can show you the last picture because I don't have the time. Okay. Anyway, so I did a ejaculation, and then I put what you call as an intraocular orbital mold to increase the intraocular volume for a better fitting of the prosthesis. After 15 days of the removal of this mold, I put a prosthesis well fitting. Now, the thing is that when histopathology of this was done, luckily it was benign. So the thing is, when you talk about this discussion, that whenever you have a patient with acute congestive glaucoma who is not responding to routine, please do a B scan. Pick up the solid exudate detachment and do an MRI. And then in this patient, what happens is that basically in the beginning B scan was not done. And then when it was done, there was a problem with the radiologist. So I got some references. In Boston Palmer Ophthalmology University of Miami, 2 patients with choroidal melanoma present acute congestive glaucoma. 1 patient was put on anti-glaucoma medication, other patient has a hazy media, and making it difficult of the posterior segment to be visualized. MRI confirmed melanoma ejaculation done. Similarly, Institute of Ophthalmology in Manchester, a patient of acute congestive glaucoma did not respond to this anti-glaucoma medication, and MRI done, confirmed choroidal melanoma ejaculation was done. The malignant melanoma of a ciliary body are very refractory treatment. Sometimes you have a case like vertex viruses, which presents as a UL melanoma, but it's a benign condition. Thank you very much.
Thank you, sir. Thank you, sir. Thank you, sir. Respected sir. Thank you. Any presenter, please? Thank you. We close the session. Let's have a photograph.